Your legs are whispering a warning most people over 65 completely ignore. Right now, 12 million Americans in that age group have symptomatic peripheral artery disease, 12 million, and most of them blamed tired legs on getting older. A vascular surgeon says that is the dangerous mistake. So why did so many people miss the signs hiding in plain sight? After 65, circulation decline accelerates 40% faster than in younger adults, but only when you stay sedentary. That distinction matters enormously. The difference between decline and recovery often comes down to 3 simple chair moves. No standing required, no gym membership, no equipment. But before we get to the solution, you need to understand exactly what is happening inside your arteries right now and why the window to act is smaller than most doctors will tell you. The body does not betray you all at once. It gives warnings, small ones first. Dr. Michael Chen is a vascular surgeon at the Mayo Clinic. He has spent decades watching what happens to the human circulatory system after age 65. And what he describes is not subtle. After 65, arterial walls stiffen. They lose the elasticity that once allowed them to expand and contract with each heartbeat. Plaque builds faster along vessel walls. The arteries can no longer dilate efficiently enough to push adequate blood down to the lower limbs. The legs, the farthest point from the heart, are the first to suffer. The clinical term for what follows is claudication. Cramping, pain during movement, numbness that comes and goes, feet that feel cold even indoors, wounds on the ankles or feet that simply refuse to heal. The 2025 American Heart Association guidelines now flag the post-65 window as the single highest risk period for circulation decline in a person's lifetime. Not the 70s, not the 80s. Right after 65 is when the slide begins and when it is easiest to stop. Dr. Chen's warning is direct. Inactivity is the #1 accelerant. Sitting still does not just fail to help. It actively makes arteries stiffer, faster. Every hour of prolonged sitting compounds the problem. The arterial wall, deprived of the mechanical stimulus that movement provides, begins to lose its responsiveness. The smooth muscle cells lining the vessel walls stop receiving the signals that keep them pliable. Stiffness becomes the new baseline. And once stiffness becomes the baseline, the threshold for serious damage drops significantly. The catalyst is not a single dramatic event. It is 1,000 ordinary afternoons in a chair, a Tuesday spent watching television, a Wednesday spent reading without getting up, a Thursday where the only walk was from the bedroom to the kitchen and back. Each one unremarkable. Each one contributing to a pattern that, viewed across months and years, looks less like aging and more like a slow emergency. And by the time most people notice something is wrong, the damage has already been building for years. 2 to 3 years before most seniors seek help, the first signs are already there. Quiet, easy to explain away, hiding in the ordinary fatigue of a Tuesday afternoon walk. The warning signs. Nobody takes seriously. The scene is familiar. A person over 65 finishes a short walk, maybe to the mailbox, maybe around the block. Their legs feel heavy, tired in a way that seems disproportionate to the distance. They sit down. The feeling passes in a few minutes, maybe less. They pour a glass of water. They tell themselves they are just getting older. They believe it completely. This is where the story takes a turn nobody expected. That fatigue is not aging. That is blood struggling to reach muscle tissue that needs it. The arteries are narrowing. The flow is restricted. The legs are sending a signal, and the brain is filing it under normal. The signal gets sent again the next day, and the day after that. And each time, the brain files it in the same place. The CDC's 2025 data is stark. Most seniors dismiss these early symptoms for 2 to 3 years before seeking medical evaluation. 2 to 3 years of compounding damage, 2 to 3 years of missed intervention windows, 2 to 3 years of a story getting harder to rewrite. The early signs arrive in a specific sequence. First comes leg fatigue after walks that used to feel effortless. The same route, the same pace, suddenly requiring twice the recovery time. Then tingling in the feet, a pins and needles sensation that appears without obvious cause, sometimes in the middle of the night, sometimes while sitting perfectly still. Then coldness in the toes, even when the rest of the body feels warm, even under blankets, even in a heated room. These 3 symptoms form the opening chapter of a story that gets harder to rewrite with every passing month. The mid-stage signs are harder to ignore, but still routinely dismissed. Cramping in the calves or thighs during light activity, climbing a single flight of stairs, walking across a parking lot, carrying groceries from the car to the front door. The skin on the lower legs begins to change. It looks shiny, pale, sometimes hairless in patches where circulation has become too poor to sustain normal tissue function. The skin feels different to the touch, thinner, almost papery, like something underneath it has quietly withdrawn. Most people at this stage have a ready explanation. Bad knees, old injury, just one of those days. They are not wrong that something is wrong, they are wrong about what it is. Which, looking back, was either incredibly brave or incredibly stupid. The decision to wait and see. Because the dangerous sign comes next. Wounds on the feet or ankles that will not heal, a blister that stays open for weeks, a small cut that becomes an ulcer, a scrape from a shoe that should have closed in days but is still raw 3 weeks later. This is not a warning anymore. This is a medical emergency. Poor circulation means the tissue is not receiving the oxygen and nutrients required for basic repair. The healing process requires blood. The blood is not arriving in sufficient quantity. Left untreated, this pathway leads to infection, to tissue death, and in the most severe cases, to amputation. The numbers are not abstract. Peripheral artery disease is the underlying cause in the majority of lower limb amputations performed in the United States each year. And the majority of those patients had early symptoms they did not act on. They had the fatigue, they had the tingling, they had the cold toes at night. They had every chapter of the story delivered to them in sequence, and they filed each one under getting older, and they kept sitting down, and the story kept writing itself without them. Everything was in place. The body just didn't know what everything was building toward. The difference between catching this early and catching it late is not a matter of degree. It is a matter of trajectory. Early detection, when symptoms are still in the fatigue and tingling stage, means the intervention is a chair and 15 minutes a day. Late detection means a surgical consultation, a procedure, and a recovery measured in months. The CDC data makes this concrete. Seniors who address circulation symptoms within the first 6 months of onset have significantly better outcomes than those who wait. The arteries are still responsive. The damage is still reversible. The window is open, but that window does not stay open indefinitely. For a while, things actually seemed fine. The symptoms would come and go, some days better than others, nothing alarming enough to call a doctor. That didn't last. The trap. The year is 2024. Somewhere in a doctor's office, a senior patient sits across from a physician. The room smells like antiseptic and recycled air. There is a paper-covered examination table, a poster about blood pressure on the wall, a small plastic model of a human heart on the counter. The doctor leans forward slightly, forearms resting on the desk, and delivers the advice without hesitation. Walk more. Get moving. 30 minutes a day, most days of the week. It is the standard prescription. It has been the standard prescription for decades. It appears in pamphlets, it appears in guidelines, it is printed on the walls of waiting rooms across the country. And for a healthy adult with normal circulation, it works. It genuinely works. But for a senior with peripheral arterial disease, with claudication, with compromised blood flow below the knees, this advice does not just fail, it actively accelerates the decline. Here is what happens. The patient leaves the office. They try to walk. They put on their shoes, step outside, and within minutes, sometimes within seconds, the cramping begins. The burning starts in the calves, specific and insistent. The legs tighten like a vice around the muscle belly. This is claudication. This is the body sending an emergency signal that the muscles are not receiving enough oxygenated blood to sustain the demand being placed on them. The pain is not subtle. It is not something you push through. It stops people cold. Literally, they stop walking. They find a bench, a wall, a car hood to lean against. They stand there, breathing through it, waiting for the burning to subside. They sit down, they wait for the pain to pass, and then they go home, and they don't try again tomorrow. Because why would they? The last attempt ended in pain. The brain has now logged movement as a threat. The association is made. Movement equals suffering. The body learns fast. And then the patient made the one decision that changed everything. They stopped moving entirely. This is the pain avoidance cycle, and it is one of the most destructive forces in geriatric vascular health. Discomfort leads to inactivity. Inactivity leads to faster circulation decline. Faster circulation decline leads to more severe discomfort the next time any movement is attempted. The cycle feeds itself. Each rotation of the loop pulls the patient deeper into sedentary behavior. Each day of stillness accelerates the narrowing of the arteries. The body, deprived of the muscle contractions that help push blood through the venous system, begins to compensate less and less effectively. The legs that hurt during a 5-minute walk now hurt during a walk to the bathroom. The NIH published findings in 2024 that should have made headlines. Sedentary geriatric patients show the steepest vascular deterioration curves of any demographic studied. Not just steeper than active seniors, steeper than any group. The rate at which arterial function declines in an older adult who stops moving is not linear, it is exponential. Week 1 of inactivity looks manageable. Week 6 looks catastrophic. And no, I'm not making that up. These are the numbers coming out of federally funded longitudinal studies tracking thousands of patients over multi-year periods. The data is unambiguous. Now, someone might say, fine, walking is painful, but what about the gym? What about resistance machines, stationary bikes, treadmills set to low speed? What about supervised exercise programs? And this is where the second failure of standard advice reveals itself. Gym equipment was not designed for this population. It requires balance. It requires coordination. It requires joint integrity that many seniors over 65 simply do not have. A stationary bike demands hip flexion that aggravates arthritis. A treadmill demands a level of postural stability that puts fall risk at unacceptable levels. Resistance machines require the ability to safely mount and dismount weighted seats in ways that, for someone with compromised lower limb circulation and reduced proprioception, create genuine injury hazards. The gym is not a neutral environment for this population. For many seniors with circulation problems, it is an obstacle course with no safe path through it. The clock was already ticking. The patient just couldn't hear it yet. So the senior follows the advice, or tries to. They walk and it hurts. They attempt the gym and it is inaccessible or frightening or both. They return to the couch, they watch television, they feel guilty about not exercising. The guilt adds psychological stress. Psychological stress through cortisol elevation further constricts blood vessels. The arterial walls tighten, the flow diminishes, the symptoms worsen. And at the next doctor's appointment, the advice is the same. Walk more, get moving. The cycle does not break, it deepens. What the standard advice never accounts for is that the mechanism of circulatory improvement does not require high-intensity movement. It does not require standing. It does not require any movement that triggers the pain threshold at all. The muscle contractions that stimulate venous return, that activate the body's natural second pumping system, can be generated from a seated position. Small movements, targeted movements, movements that activate specific muscle groups in the lower legs without ever crossing the threshold into claudication-triggering exertion. This was not a mystery waiting to be solved. The physiology was known, the research existed. The gap was in translation. The gap was between what the science showed and what the advice actually said. One vascular specialist, reviewing cases of accelerated decline in elderly patients who had ostensibly been given appropriate exercise guidance, identified the pattern clearly. The advice was technically correct for a different patient population. It had been copy-pasted onto a group for whom it was physiologically contraindicated. She documented her findings. She presented them at a regional conference in late 2023. She recommended a complete restructuring of the exercise guidance given to seniors with diagnosed peripheral arterial disease. Nobody listened. Nobody listened. And the patients kept declining. But that window, the one that vascular surgeons describe as the last viable period for intervention before irreversible damage sets in, that window was still open for some of them, barely, but open. What was needed was not more walking. What was needed was something else entirely, something that worked with the physiology instead of against it, something that could be done anywhere, by anyone, without pain, without equipment, without risk of falling. Someone specific saw it coming. Dr. Rachel Monroe, a geriatric physical therapist practicing out of a rehabilitation center in Portland, Oregon, had been documenting the pain avoidance cycle in her own patient population for 3 years before the NIH study confirmed what she already knew. She had watched patient after patient arrive at her clinic in worse condition than when they had received their original diagnosis, not because the disease had progressed unusually fast, but because the advice they had been given had accelerated it. She would review their intake forms, trace the timeline backward, and find the same pattern every time: a diagnosis, a pamphlet, a failed attempt at walking, and then months of stillness. She wrote a formal recommendation to the hospital's internal medicine department in January 2024, urging them to replace standard walking prescriptions for PAD patients with structured seated exercise protocols. The recommendation was filed. It was acknowledged. It was assigned a reference number. Nobody changed the pamphlets. The reckoning. The year is 2025. A clinical trial is concluding. The researchers are seated around a conference table, printed data sheets spread across the surface, laptops open, a projector throwing numbers onto a white wall. The results are being compiled, and what they are seeing in the data is not what anyone expected to see this quickly. But the version you have heard, that is not the full picture. The public understanding of exercise and circulation tends to follow a simple logic. More movement equals better blood flow. High intensity equals high benefit. Sweat and effort are the currencies of cardiovascular health. This framework is not wrong for the general population, but it is dangerously incomplete for seniors with compromised lower limb circulation. And the research that has emerged over the past 2 years does not just complicate that framework, it dismantles it. Dr. Sarah Patel is a geriatric exercise physiologist. She has spent the better part of a decade studying how the aging vascular system responds to different types of physical stimulus. In 2023, working with a team at a university-affiliated rehabilitation research center, she identified a specific gap in the existing literature. There were extensive studies on high-intensity interval training and cardiovascular outcomes. There were extensive studies on walking programs and peripheral arterial disease. There was almost nothing on low-intensity, seated, lower limb-specific movement in post-65 patients with diagnosed vascular compromise. She designed a protocol, 3 seated movements, each one targeting a specific muscle group in the lower legs, each one calibrated to activate venous return without triggering claudication. She called it a minimal threshold vascular activation protocol. Her colleagues called it chair exercises. Both descriptions are accurate, and the timing of what happened next, almost too perfect. In 2024, a series of surgeon-led trials began running parallel to Dr. Patel's work. These were not exercise physiology studies. These were vascular surgery outcome studies. The surgeons running them were not looking at exercise at all. They were looking at amputation rates. They were tracking which patients in high-risk populations went on to require major lower limb amputation within a 3-year window following diagnosis of severe peripheral arterial disease. And buried inside the data, they found something unexpected. Patients who had been enrolled in consistent daily seated movement programs showed a 30% reduction in amputation risk compared to the sedentary control group, 30%. That is not a marginal statistical finding. That is a clinically significant intervention-level result. So yeah, not great for the decades of advice that had been sending these patients home with pamphlets about walking. The mechanism behind this is not complicated once you understand the basic physiology. The muscles of the lower legs, particularly the soleus and the gastrocnemius, function as a secondary circulatory pump. Every time these muscles contract, they squeeze the deep veins running through them. That squeeze pushes blood upward, back toward the heart. In a young, active person who spends most of the day on their feet, this pump operates continuously. In a sedentary, older adult who spends most of the day seated or lying down, it is almost entirely inactive. The heart is left to do all the work alone. The venous blood pools in the lower extremities. The pressure in the capillary beds rises. The arterial walls are subjected to increased resistance. The circulation becomes less efficient. The tissue becomes more hypoxic. The damage accumulates quietly, invisibly, in the deep tissue of the calf and the ankle and the foot. Chair-based leg exercises restart the pump. That is the mechanism. Simple, documented, reproducible. The Mayo Clinic published findings in 2026 confirming what Dr. Patel's trial data had already suggested. Chair-based leg exercises boost lower limb blood flow by up to 25% in seniors with baseline vascular compromise. 25%. That is the difference between tissue that is marginally hypoxic and tissue that is receiving adequate oxygenation. That is the difference between a wound that heals and a wound that doesn't. That is, in some cases, the difference between a leg that stays and a leg that doesn't. The Journal of Geriatric Physical Therapy published a clinical trial in 2025, 48 participants, all over 65, all with documented lower limb circulation issues, half enrolled in a daily seated exercise protocol based on Dr. Patel's 3-move program. Half continued with standard care, which meant the same walking advice that had already failed them. At 6 weeks, the seated exercise group showed measurable arterial improvement. Measurable. Not theoretical, not projected. Measured directly through ankle brachial index testing and Doppler ultrasound assessment of blood flow velocity. The technician running the Doppler would place the probe just above the ankle, apply a small amount of cool gel to the skin, watch the waveform appear on the monitor, and see something that had not been there 6 weeks earlier: a sharper peak, a faster return, a cleaner signal that the tissue downstream was receiving more blood than before. The waveform that had been flat and sluggish was now showing the characteristic double peak pattern of healthy arterial flow. The control group showed continued decline. At 6 weeks, this is not a slow intervention. This is not a program where you wait 18 months to see if anything changes. 6 weeks of consistent daily seated movement produced arterial changes that were detectable with diagnostic imaging. The 3 moves Dr. Patel designed are not arbitrary. Each one targets the specific muscle groups that contribute most to venous return in the lower extremities. Each one can be performed in any chair, a kitchen chair, a recliner, a wheelchair, a couch with firm cushions. Each one requires no equipment, no gym membership, no balance, no joint integrity beyond what is needed to sit upright. Each one has a direct physiological mechanism linking the movement to improved blood flow. The first move activates the soleus through ankle flexion. The heel lifts slowly off the floor, 1 inch, 2 inches, while the toes stay planted flat. The deep calf muscle contracts with each lift, holds for a beat at the top, then lowers with deliberate control. That contraction squeezes the veins running through the muscle belly and pushes blood upward toward the heart. 10 repetitions. Slow, intentional. Each one a small pump stroke. The second move targets the gastrocnemius through toe raises. This time the heel stays grounded and the toes lift, all 5 together, rising toward the shin. The upper calf engages with a firm contraction that you can feel if you press 2 fingers lightly against the back of the leg while you do it. The muscle hardens under your fingertips. That is the pump activating. 10 repetitions, same deliberate pace. The third move combines both in an alternating march pattern that mimics the lower leg mechanics of walking without requiring a single step. Left heel up, right toes up, then switch, right heel up, left toes up, in a steady rhythm that keeps both pumps cycling continuously. The motion is small, the effect is not. Each alternating contraction drives blood through a different segment of the venous network, creating a wave of upward pressure that the heart does not have to generate alone. Each of these 3 moves sits well below the pain threshold that stops seniors from exercising in the first place. Each one can be done during a commercial break, during a phone call, during the morning news. The chair does not move, the person does not stand, the risk of falling is 0. The window that the vascular surgeons describe, the one that closes as arterial disease progresses from reversible to irreversible, it is still open for a significant portion of seniors who are currently doing nothing. Not because they don't want to help themselves, but because nobody has told them what to do that actually works for their specific physiology. Nobody has handed them a 3-move protocol backed by clinical trial data and explained clearly that they can do this in their living room chair while the evening news plays. The gap between what the research shows and what patients actually receive as guidance remains staggering. Dr. Patel's protocol is not yet standard of care. The surgeon-led trial data on amputation risk reduction has not yet filtered into the pamphlets sitting in waiting rooms. The 25% blood flow improvement finding from the Mayo Clinic has not yet changed the advice that most primary care physicians give to their elderly patients with leg circulation concerns. The patients who need this information most are still being told to walk more. And the clock had already started. The patients had 6 weeks before the measurable window of arterial improvement in Dr. Patel's trial began to close for the control group. And the clock had already started. Start here, right now, your ankles. The real question isn't whether you'll move, it's when.